Greetings, everyone. My name is Mark Kim, and I'll be your host for today's webinar. I would like to start by expressing our gratitude to everyone that is participating in our third NITS webinar. Today, we will have three wonderful and interesting presentations by our guest speakers to share the worldwide experience of current treatment of benign biliary and postoperative anastomotic strictures with the CAFIS stent. If you have any questions, please type and send in the questions through the question tab on your screen. The moderators will answer your questions after each presentation is completed. We are pleased to have Professor Arthur Kapis from the Royal Prince Alfred Hospital, Australia, and Professor Donggi Lee from Gangnam Severance Hospital, Korea, as our two moderators to lead today's webinar. Now, I would like to pass on and start the webinar. Professor Kapis and Professor Lee, please lead us with the webinar. Thank you.
So thank you very much and welcome everybody to this wonderful seminar on biliary interventions focused around the CAFIS stent. Really, I'm looking forward to these three presentations which explore different uses of the device in different pathologies involving biliary strictures. And I want to pass on to my co-chair, Dr. Lee, Professor Lee, who will make some comments and then introduce our first speaker. Thank you.
Yeah, thank you, Cafe. In this webinar, we will have the three excellent world famous presentator. And without further ado, I would like to introduce and invite first speaker, Dr. Tachya Sato from University of Tokyo Hospital, Japan. He will be talking about outcomes of management for benign hepatico-jejunostomy stricture. Dr. Sato, please. Would you start?
Thank you. Yes, thank you for your kind introduction. Can I show my slide? Can you see the slide? Okay. Hello, everyone. I'm Tachya Sato from the University of Tokyo Hospital. It's my great pleasure to share our experience with the endoscopists worldwide and two great professors in this field. I also appreciate for TEV Medical for inviting me as a speaker. Today's my talk is about endoscopic management of benign hepatico-jejunostomy stricture using a free covered metal stent. I have no COI. Hepatico-jejunostomy anastomotic stricture HJAS is a late adverse event of pancreatic biliary surgeries, and the incidence is reported to be 3 to 30%. HJAS can be a cause of cholangitis and obstructive jaundice, and biliary drainage is necessary for such patients. However, endoscopic management of HJAS is difficult due to surgically altered GI anatomy. That's why HJAS has been managed by percutaneous drainage or surgical repair. In the last decade, double balloon endoscope assisted ELCP, DBELCP, facilitates endoscopic treatment for HJAS using balloon dilation and plastic stent placement. This slide shows a summary of published data of HJAS treatment by DBELCP. The recent two studies include more than 100 patients, and both Roux-Y and below 2 reconstruction were included. As a result, biliary drainage is successful in 77 to 89%. This data shows that DBELCP was a feasible option for HJAS treatment. There are two goals in benign HJAS treatment. One is biliary drainage, and the other is stricture dilatation. The final goal of the treatment is stent-free status with no recurrence. In early days of DBLCP, balloon dilation was mainly performed for stricture management. The stricture resolution rate is as high as 71 to 100%, whereas the recurrence rate is also high, as 34% to 71%. Thereafter, plastic stent placement was introduced to improve the treatment outcome. In these two studies, the stricture resolution rate was 85% and 52%, and the recurrence rate is 27% and 10%. It seems to be better than the treatment by the balloon dilation only. However, this strategy needs multiple DBELCP sessions, which can be a patient burden. We also evaluate the predictive factors for stricture resolution. By multivariable analysis, scar-like appearance around the anastomosis, which is whitish mucosal change shown in picture A, and post-operative time more than 12 months were predictors for stricture resolution. Conversely, HJAS without scar-like appearance, like shown in picture B, or HJAS developed within 1 year after surgery, are seemed to be refractory to balloon dilation and plastic stent placement. These refractory strictures required a new treatment option. Recently, the accumulated evidence suggests that temporary placement of a free-covered self-expander metal stent is an effective treatment modality for benign biliary strictures, and many guidelines recommend this strategy. However, the data is lacking about the free-covered SEMS treatment for HAAS. Therefore, we conducted a prospective clinical trial to evaluate the safety and effectiveness of free-covered metal stent for refractory benign biliary strictures. This is a single-center, single-arm exploratory clinical trial, and the results were published in Endoscopy last year. In this study, we enrolled a patient with refractory BBS, which is defined as resistant to plastic stents for longer than 6 months. A total of 30 patients were included in the study, and not only HAS, but also post-LDLT strictures or stricture due to chronic pancreatitis or post-cholecystectomy strictures were included. In this presentation, we focus on the results of HAS patients. In this study, we use nitrous cafe stent manufactured by TEF Medical and developed by Dr. Asa Cafes. This is a free-covered metal stent developed especially for benign biliary strictures. Here I pick up 3 features of cafe stent. First, the stent has central waist structure to prevent stent migration. Because stent migration is reported to be associated with treatment failure, anti-migration property is necessary for free-covered metal stent. The diameter of the central part is 2 mm smaller than that of the stent end. When placing the stent, the central portion of free-covered metal stent should be located at the site of stricture. Second, platinum string is attached to the distal end of cafe stent for easy removal of the stent. In cases with HAAS, we use biopsy forceps and grasp the string to remove the stent through the working channel of double barrel endoscope. Third, the delivery system is as thin as 9 inch in diameter. We can insert the stent through the working channel of double barrel endoscope. By considering these features, we thought cafe stent can be applied for HAS treatment. Other endoscopic equipment is shown in this slide. We use a short type double barrel endoscope, the length of which is 155 cm, and the diameter of working channel is 3.2 mm. This slide explains endoscopic procedures. First, double barrel endoscope is inserted to the anastomosis site. Second, biliary cannulation is achieved with an ERCP catheter and 0.025 inch guide wire. Anastomotic stricture is confirmed by endoscopic view and also cholangiography. Next, we perform balloon dilation of the anastomosis site. After balloon dilation, plastic stent is inserted into the bile duct contralateral to the free-covered metal stent. I mean, if we plan to place free-covered metal stent in the left bile duct, plastic stent should be placed in right biliary duct. I will explain it later. Finally, free-covered metal stent is inserted across the anastomotic stricture. Stent indwelling period is defined as 3 months in this study. So to determine for which branch to place free-covered metal stent, we usually focus on 3 points. First, bifurcation should not be located nearby the HAAS. In this figure, the bifurcation of B2 and B3 is about 3 cm proximal of the anastomosis, which is enough for free-covered SEMS placement. Second, that the diameter of bile duct should be large enough. We think at least 4 to 5 mm is necessary for free-covered metal stent placement. Third, the axis of the bile duct and the endoscope should be in the straight line. Because DB double barrel endoscope does not have an elevator for insert the metal stent, selecting the appropriate bile duct is important to easily insert the metal stent. In this figure, the left hepatic duct is in the same straight line with the double barrel endoscope. So considering these 3 conditions, the left hepatic duct is usually a good candidate for metal stent. And I'd like to explain about concomitant plastic stent placement. When placing free covered metal stent at the hepaticojejunostomy anastomosis, contralateral bile duct is obstructed by a stent membrane and can develop cholangitis or liver abscess. Therefore, we always place plastic stent in side-by-side manner to prevent cholangitis. We call it rescue stent. And after 3 months, the DBE is inserted again, and free covered metal stent is removed by grasping the string using biopsy forceps. In most cases, free covered metal stent can be removed through the working channel of double barrel endoscope. After stent removal, the stricture resolution was assessed by endoscopic view and cholangiogram. Stricture resolution is also confirmed by smooth passage of inflated extraction balloon and contrast medium easily flowing out into the jejunum. Here I will show you the video. We can see the anastomotic stricture, which was not resolved after multiple plastic stent sessions. Biliary cannulation was achieved, and cholangiography also demonstrated biliary stricture at the anastomosis site. In this case, we plan to place metal stent in B2, but bifurcation B3 located nearby the anastomosis. So we placed 5 French plastic stent into B3 as a rescue stent. Next, B8 is selected by guide wire, and another rescue stent is inserted to B8. We use 7 French plastic stent for the second rescue stent. Finally, guide wire is inserted in B2 and cholangiogram obtained, and free covered metal stent inserted into B2. The stent is deployed under fluoroscopic and endoscopic guidance. Here we can see the marker of the central portion located at the stricture site. And because the string is 10 cm long, we have to pull back double barrel endoscope to deploy the string. After 3 months, free covered metal stent was removed by grasping the string by biopsy forceps. It can be removed through the working channel of double barrel endoscope. And the plastic stent was removed using a snare. And we can see on endoscopic view, the anastomosis stricture is very good condition, very well resolved. And also balloon occluded cholangiogram is performed, suggesting stricture resolution is confirmed. The balloon was easily passed through the anastomosis site. We can see good opening in the last of my video. So we move on to the results of our study. This slide shows characteristics of 12 patients with HAAS. The male consists of 41%, and the median age was 72 years old. The type of surgery is PD with Lewy reconstruction is 41%, PD with below 2 reconstruction in 25%, and extrahepatic bile duct resection with Lewy reconstruction is 33%. Time from surgery to initial biliary drainage is 8.4 months. And this is the outcome of the treatment. Free covered metal stent placement was successful in all patients with a median procedure time of 55 minutes. Stent diameter was 6 mm in 3, 8 mm in 6, and 10 mm in 3. In most cases, 4 cm stent was used. And concomitant plastic stent is used in 91%, to prevent cholangitis. The stent indwelling period is 91 days, and stent removal is successful in all patients. Finally, stricture resolution at 3 months is 100% in this study. Adverse events were observed in 1 out of 24 DBLCPs, I mean 2 DBLCPs for each patient. One moderate GI perforation was diagnosed by pneumoperitoneum on CT scan. The patient was recovered with conservative management. And one patient experienced asymptomatic migration of the metal stent. In this case, the stricture resolution was confirmed by DBLCP. There was no stent occlusion at all. And for long-term outcome, during the follow-up of 3.3 years, the stricture recurrence was observed in 25%. As the number of patients was limited, we have to accumulate more patients to evaluate the long-term outcome. So this is a summary of our prospective trial. 3 months placement of cuff stent successfully resolved the refractory HAAS. Placement and removal of cuff stent were technically successful in all patients. Adverse event rate was acceptably low, and during the follow-up of 3.3 years, 25 of HAS recurred. As the final part of this presentation, I would like to discuss about 3 questions about free covered metal stent treatment of HAAS. The first is free covered metal stent useful not only for refractory cases, but also for initial treatment of HAAS? The answer is yes, we believe that metal stent is also effective for initial treatment. We think metal stent can improve the rate of stricture resolution, shorten the treatment duration, and also decrease stricture recurrence. This is preliminary data of free covered metal stent placement as an initial treatment of HAAS. When comparing 40 patients of metal stent with 38 patients with plastic stents, stricture resolution rate tend to be higher in free covered metal stent group, but there is no statistical significance. And treatment duration and number of DBLCP is significantly shorter and smaller in free covered metal stent group. The recurrence rates was comparable in this cohort, but further evaluation is necessary. And the second, how long is the appropriate indwelling period? The answer is 3 to 6 months is appropriate, we think. But we agree that the longer duration of metal stent placement would contribute to better resolution and less recurrence. But we should consider the increased risk of migration and difficult stent removal. The appropriate period should be evaluated in the future trial. And the final question, any modifications necessary for cuff stent? I think cuff stent is a good choice for HS treatment, but I'd like to propose 2 points to further improve the stents. The first, platinum stent is too long for HS treatment, as you can see in my video. So maybe shorter string is better for HS treatment. The second, the thinner delivery system would be better because the diameter of working channel of double endoscope is limited. So we hope modified cuff stent, which is dedicated for HAS, will be available in the near future. So this is my take-home message. Temporary placement of free covered metal stent is an effective option for the endoscopic treatment of HAAS. Because the stricture resolution rate is very high, free covered metal stent can be a first-line treatment for HAAS. Thank you for your kind attention.
That was a very nice presentation, Sato. Excellent, well done.
Thank you.
We have a question, but before I ask you the question from the Q&A, you had a very low rate of migration. And I wonder, do you think the reason for this is because you also had plastic stents beside the metal stent?
Yes, I agree with you. Because metal stent itself can migrate, but we place 1 or 2 plastic stents beside the metal stent. Maybe it helps to not to migrate the metal stent.
Okay.
And
And
sorry.
another question is did you have experience string breakage during stent removal?
Yes.
Yeah.
Actually, 1 or 2 cases. In such cases, we use snare to remove the stent.
Yeah. I also have the same situation several times, but it is not a problem because when you use the grasping forceps, you can remove the stent. Even the distal end located in the CBD, you can remove it under the fluorescent guidance. And you talk about the indwelling time, 3 months to 6 months. Of course, longer is better.
Yes.
How do you think about the indwelling time, ideal indwelling time, Dr. Cafe?
Yeah, this is a very good question. And initially, when we used this stent, we thought that maybe we should be 3 months only, essentially because we wanted to be avoiding embedding of the stent in the bile duct. And in fact, in some cases, the patients would come back later. And so the time of indwelling in our initial study was actually almost 4 months. And I think subsequent to that, we've moved even further up. And often now in our patients, we will indwell the metal stent for 5 or even 6 months. But as Sato said, you run the risk of migration, you run the risk of string degradation and breakage, and possibly a little bit of embedding and a secondary stricture formation. But this doesn't seem to be a big problem.
Yeah.
Okay.
According to the Sato's data, you did not so experience cholangitis frequently. You experience only 1 case is cholangitis. Do you think there's some possibility of the stent occlusion by the sludge formation inside of the stent?
Yes, there's a possibility because even after 3 months, we can see many sludges around and inside the stents. But in this point, maybe bile flow is preserved, so cholangitis not occurred. But maybe with prolonged indwelling period, cholangitis can be occurred, I think.
But I think the another reason you showed so low rate of cholangitis is you simultaneously inserted the plastic stent beside of the cafe stent. In my experience, there is a high rate of sludge formation inside of the stent. Therefore, I asked some modification of in the membrane by such as the hydrophobic coating. But I asked to the Taewoong company, but still there's no answer. I hope there's some modification to prevent the sludge formation. And the one more question, you showed only the data of endoscopic management, but did you have a chance to compare the data, endoscopic treatment versus the percutaneous treatment?
Yes, but actually, we performed Dblcp first for the patient with altered anatomy, and we only performed percutaneous treatment for the patient where the Dblcp was failed. So there is selection bias, I think. And actually, I have no experience for the comparing the results of endoscopic and percutaneous treatment.
Because in Korea, the many institute, the double balloon endoscopy is not available. Many institute prefer to perform the percutaneous approach first. In those cases, we indwell the 16 French, the large bore catheter for 3 or 4 months. But in those cases, there is some high rate of recurrence, about 20 to 30%, if you follow up this patient for several years. That's the problem. Therefore, I think the full cover metal stent is better than the large bore, the plastic catheter. Yeah.
I agree.
And the last question, did you experience the total occlusion of hepatico-jejunostomy?
Yes. There are
How
some
do you
cases.
treat them? The puncturing it by the needle life or the other method?
Yes, actually, I use needle catheter or very thin catheter to push around the anastomosis site. But if it failed, we combined percutaneous drainage or even US guided drainage and use rendezvous technique to facilitate the anastomosis repair.
Yeah, but because the needle puncture is basically the blind procedure, in those cases, I prefer to use the magnet compression anastomosis.
Yes.
Okay, anyway, any other questions? Okay, thank you very much for the nice presentation. Dr. Kape will introduce the second the presentator.
So our next speaker is Dr. Joshi, who is a consultant hepatologist at the King's College Hospital in London. He completed a PhD in liver fibrosis, but also concomitantly trained in ERCP at the King's College Hospital and has a vast experience with ERCP in liver transplant patients. And we will hear his presentation on the endoscopic treatments of post-transplant anastomotic strictures. Thank you, Professor Joshi.
Thank you very much. Thank you for the kind invitation and introduction. So yes, I'm going to be talking about the endoscopic treatment of post-transplant anastomotic strictures and really try and define the role of the cafe stent. So the overview, we'll have a little overview of benign biliary strictures, the etiologies, and then, like I said, really going to highlight the role of the cafe stent. Within that, I'm going to share the experience we have had at King's in London, but also present some of Professor Lee's data as well, which is very relevant. And then also explore some new indications for the stents, which I think a lot of us are doing, and I'll show you some of our data again. So if we have a quick overview of benign biliary strictures, I think these are sort of the four main subgroups. I think PSC, primary sclerosing cholangitis, is a topic in itself, and I'm not going to touch on that today. We could have a webinar on that alone. There are the post-surgical causes, and Professor Sato has already spoken very eloquently about sort of bilioenteric anastomoses and how we should manage that. And one of the key ones here is obviously anastomotic strictures. There's inflammatory causes, some of them which are quite common, chronic pancreatitis, IgG4 related cholangiopathys, and then very rare ones these days, which is AIDS related sort of strictures. And then there are other causes as well. So this is trauma, portal biliopathy, choledochal varices, which can cause benign strictures. And also then we have the non-anastomotic strictures, the ischemic strictures, which often occur with hepatic artery thrombosis. So in normal days, we'd be in an audience together. I would ask the audience, what would one do here? But I'm gonna have to answer the question as well. So this is a lower CBD stricture. It's not a transplant patient. And the question is always, should we use a plastic stent? Should we use 10 French stents? Should we use multiple stents? Or actually, should we be using a fully covered metal stent? So there's a lot of literature now on the use of fully covered metal stents. The data on your left-hand side is a study, a randomized controlled trial from the US published in JAMA in 2016. And what they showed, this was a non-inferiority study, and there was equivocal sort of resolution of strictures with both covered and plastic stents. And perhaps with this graphic that you can see, there was a sort of an increased time to sort of reduced time to stricture resolution. So perhaps suggesting better efficacy. The data on your right-hand side, this was grouped from sort of a worldwide experience of fully covered metal stents, and this was in patients with chronic pancreatitis, post-transplant, post-cholecystectomy strictures, and again showing good resolution with fully covered metal stents. So I think we as a group are now certainly moving more across to using fully covered metal stents as our experience increases. So if we quickly look at the pros and cons of plastic and covered metal stents, covered stents and plastic stents are very easily removable. Covered stents, though, have a better patency, they have a better function as well, and they can actually modulate the stricture, which is often beneficial in certain patient groups. They're less likely to block, but one of the problems can be is that they can migrate either up the bile duct or down into the duodenum and beyond. And one always has to remember that if you insert it across the hilum, then you have to remember about the contralateral duct, and you need to provide drainage there as well. So this is back to our patient. In this case, we did insert a fully covered metal stent. You can see it placed there, good drainage of contrast. And when we came back 3 months later, showing excellent stricture resolution, and the patient did very well after that. One word of warning, this is a bit of tongue-in-cheek. This is a patient who underwent liver transplantation with a fully covered metal stent in situ. And at the time of their explant, you can see this foreign material, and this is vegetable. So you do keep the bottom end of the bile duct open and you will get reflux of contents. This was not the reason why the patient was transplanted, I hasten to add. So let's move on to sort of the main sort of topic and sort of area of my presentation, which will be post-transplant anastomotic strictures. So biliary adverse events occur in about a quarter of patients. And then in terms of the sort of stricture formation, we have anastomotic strictures and non-anastomotic strictures. Anastomotic strictures are more common. They affect up to sort of 12% of patients following liver transplantation, more so in living donor liver transplantation, and that's a combination of mucosal ischemia and fibrosis. And here is an example of an anastomotic stricture. So the question then is, should we be using plastic stents, multiple plastic stents, or should we be using covered metallic stents? This is taken from a recent publication in liver transplantation, and these are randomized control studies comparing multiple plastic stents versus covered metal stents. And you can see that there's a similar efficacy. There's good stricture resolution if you use multiple plastic stents. And again, complication rates can be comparable. I think it really does come down to what you're comfortable with. Certainly in the UK, multiple plastic stents were sort of in fashion about 10 years ago, but certainly not so now. And we are moving across to fully covered metallic stents. So the cafe stent, Professor Sato has already spoken about its unique design, but it does come in a number of different lengths and a number of different diameters. Personally, I have to say my sort of experience has been with the 8mm stents and the 10mm stents of 4cm length only. It has this quite unique anti-migration waist and these long retrieval wires, which you can then sort of place into the duodenum and allow removal later on. And the key thing is that this is an introductal stent, and you're providing treatment of the stricture where you need it most. So this is the original study performed by Professor Cafes and his group. I think if you look on the left-hand side, there's quite a standard protocol of how we manage anastomotic strictures. We've already heard comments that within this study, it was only left in for 12 weeks, but we think maybe this can be sort of increased. And you can see good stricture resolution with both the covered metal stents and the plastic stents, and complication rates also, which were actually favored the metallic stent overall. The paper also sort of mentions that there was a reduced number of ERCPs required for stricture resolution. So in theory, there could be a cost saving instead of having to bring patients back. And within this study, there was no stent migration, which certainly can happen if you have your standard Wallflex fully covered stent. This is a video of a cafe stent insertion. So this is in a 45-year-old patient who's transplanted for alcohol-related liver disease. You can see a dilated recipient duct, and you can see me here struggling to cannulate the anastomosis. I'm using a Terumo guide wire, but eventually I am successful, and we get across, and here is evidence of the dilated donor ducts, and then a stricture. I think what might be quite good to discuss is whether one should dilate before stent insertion. In this case, you can see I did dilate. And then here comes the stent. It's a 10 mm diameter, 4 cm cafe stent. And again, a bit like how we demonstrated before in the previous talk, you want the sort of middle aspect of the stent across the stricture to provide the greatest sort of resolution of that stricture. So we are deploying very slowly. You can see the stent is opening up. And then finally, the bottom end is released. One comment I would always make is if you're unsure, deploy the stent higher, sort of above the stricture, as opposed to lower, and then you can always bring it back using the retrieval guide wires just to bring it back a little bit. If it's too low, then essentially you have to start all over again, and that can be a waste of a stent. So very easy. It's a long wire as well, so you do have to sort of sometimes refresh the memories of your nursing staff if they're not used to using the long wire. So here, very good sort of insertion of the stent perfectly across the anastomosis. So this is again further evidence of the stent doing a very good job. You can see the stricture in picture A. We've placed the stent in B, and then when we've come back after 3 months, we see good stricture resolution with a balloon cholangiogram. So what I want to share with you now is our experience of the cafe stent at King's. We essentially moved over to using the cafe stent for post-transplant anastomotic strictures in December 2016. So we've had some experience. Our protocol is very similar to the published protocol by Professor Cafe's study. We do leave it to the endoscopist's discretion as to whether a sphincterotomy is performed. You don't necessarily need a biliary sphincterotomy, and also it's the endoscopist's call also whether there's balloon dilatation of the stricture. We try and bring the patients back after 12 weeks, but that's not always the case. And during all this time, patients are followed up in the transplant clinics. So these are our outcomes. You can see at the top of your screen is the improvement in biochemistry, there's improvement in cholestatic liver markers and bilirubin, also in patients that were jaundiced. And then looking at our sort of patient outcomes, we had 62 patients who had stent insertion. And at the time of writing, we had 56 who'd had them successfully removed. We had good initial stricture resolution, 54 of 56, and 42 long-term had ongoing stricture resolution. It's interesting, 10 patients did have stricture recurrence who then went on to have further cafe stent insertion. One patient had a biliary reconstruction, another patient had plastic stent insertion. And when we've looked back as to why some of these patients had stricture recurrence, these patients sometimes had very early stricture formation, so within 3 months of their transplant, but also had an associated bile leak. So perhaps suggesting that these strictures were, slightly more than just tissue fibrosis. There's inflammation. And the way we've sort of looked at it now is we would consider placing a further cafe stent at the follow-up ERCP, irrespective of what the sort of the cholangiogram looks like. In terms of complications, overall, our complication rate of insertion and removal was about 15%. Cholangitis was reported. We were able to remove all of them, but we did have a detachment of a removal string, and I'll show you some images of how I ran into trouble quite recently. But cholangitis does occur, and again, Professor Lee has also mentioned that there's a buildup of sludge and debris. So we do recommend there's a balloon trawl to try and clear the ducts, and obviously they have antibiotics irrespective, given that they're post-transplant. No case of ours had stent migration either up the duct or down, which we were very happy with. So in terms of detachment of removal strings, this is a recent case I was involved with. This is a patient who was transplanted for cystic fibrosis related liver disease, and they had an anastomotic stricture for which we placed a cafe stent. I think in hindsight, if you look at the final cholangiogram there, the top end of the stent has opened up very nicely, but the bottom end hasn't quite opened up. And I think we were sort of quite slow to appreciate that maybe there was a stricture in the lower CBD or the recipient duct. So at the time of removal, which was delayed due to COVID, so rather than 3 months, he came back after 5 months. You can see we tried to remove the stent, but the strings became detached, and you can see, which is always very upsetting for anyone who has this experience, that the wires start to unravel, and then you're sort of left with the stent up the duct. So we were able to cannulate the lower duct, and you can see that there is narrowing of the recipient duct there. And then this is taken from Professor Lee's paper showing insertion of grasping forceps into sort of the biliary tree, engaging the stent, and then one can actually remove it. In this case, due to the sort of small diameter of the recipient duct, actually I had to insert sort of wire-guided biopsy forceps, which are available, which engage the stent, and then slowly I was able to bring it out. So it can happen, but usually you can get it out with grasping forceps. And this is the case. So we were able to remove the stent, and then we stented the lower biliary tree, the recipient duct, to ensure there was good drainage. So moving on to living donor liver transplantation, I've shown you our data. All those patients were deceased donor liver transplants recipients. This is a case report which we published in a 40-year-old patient who's transplanted for NAFLD related cirrhosis, who had bilateral strictures of the anastomosis of the right anterior and the right posterior ducts. And actually what we were able to do is insert bilateral cafe stents. These were both 8mm diameter stents. And then after 3 months, we had good stricture resolution and improvement in biliary drainage. But what I want to show you is sort of much better data rather than a simple case report. And this is from Professor Lee's group in Seoul. Again, very similar numbers, 63 patients who underwent cafe stent insertion. I think what's very interesting here is that Professor Lee's group has had experience with a different length of stent, but also perhaps even the smaller diameter stent, the 6mm diameter stent as well. Their complication rate was very low, and again, cholangitis seems to be one of the recurring themes when sort of using these stents. In terms of their overall outcomes, they had excellent technical success rate of 100% and good, again, stricture resolution at the time of removal of the stent. There was stricture recurrence up to 24%. And again, maybe Professor Lee can comment in the discussion as to whether he thinks there are any particular risk factors for which patients are likely to have stricture recurrence. And again, there was further use of further cafe stents, a plastic stent in one case, and also a percutaneous drain. So again, the cafe stent seems to have very good efficacy in living donor liver transplantation as well. This is further cholangiograms taken from Professor Lee's study, again showing stricturing, which sort of look quite angulated, but with time the cafe stent does open up, and at the time of removal you can see there's complete resolution of the stricture and a good clinical outcome there. So what are the other indications for the cafe stent? This is a very small publication we sent through and was listed as an abstract at the British Society of Gastroenterology in 2019. Given our sort of good experience with the cafe stent, we started using it in non-transplant patients. And this sort of very small case series showed that we were using it for bile leaks from across the cystic duct, or even sort of post-hepatectomy. And also in patients with hilar stricturing, we were using them sort of bilaterally. We tended to use the 8mm stents more. And again, we showed good clinical resolution of the leak or stricture resolution in all of the cases. So really our sort of take-home messages in these groups of patients, non-transplant patients, is that you can use them for common hepatic duct strictures. Beware of the hilum, and if you are going to traverse the hilum, then you may well need bilateral stents. The 8mm diameter stent seems to be very good for this. And again, maybe even the 6mm stent has a better role, and there's good clinical efficacy, and again, good safety profile. So this is another example of a patient we've used cafe stents in. This is a 45-year-old female with known portal vein thrombosis, portal cavernoma formation, and choledochal varices, and she was getting recurrent cholangitis. And this is the MRCP. You can see the stricturing of the common hepatic duct, but also perhaps some tapering of the lower bile duct as well, suggesting sort of indentation from these varices. So we proceeded to ERCP. And what you can see here is the cholangiogram. The lower sort of CBD tapers, there's dilatation of the left side, and also there was dilatation of the right side as well. So the way we managed this was to, first of all, insert a fully covered metal stent into the lower bile duct, so to modulate the stricture formation there. And then we proceeded to gain right and left duct cannulation, and then we proceeded to insert bilateral cafe stents. And this was our final cholangiogram appearance. So you've got 3 stents inside you, bilateral cafe stents, your fully covered metal stent, and then you've got your deployment wires, which are now sitting in the duodenum. So we brought her back after 3 months, and this is the outcomes. A very good cholangiogram. We performed a balloon cholangiogram. You can see resolution of the stricturing of the right and left sides, but also of the lower bile duct as well. And almost 3 years on, this lady remains sepsis-free and is doing very well for her sort of biliary stricturing disease. So what about future directions? Well, as we sort of understand the role of the cafe stent more, we're trying to sort of work with other groups within the UK, and maybe we should be more ambitious. Maybe we should have a worldwide audit of how we're using these stents. But within the UK at the moment, we've got 15 centres who are kindly sending through their data, and we're looking not only in transplant patients, but also other uses as well. And we're hoping to learn from each other with this. So this is my last slide. I think I've shown you a very quick overview of the etiology of benign biliary strictures. And we've really concentrated on post-transplant anastomotic strictures. I've shown you good sort of clinical data in living donor liver transplant recipients, but also in deceased donor liver transplant recipients, showing good clinical outcomes, good stricture resolution, and a very good safety profile. And also we've sort of slightly touched upon emerging indications of the use of this stent, and hopefully with better sharing of data and knowledge, we can further define a role for the cafe stent. So I'm going to stop there. Thank you very much. And I look forward to taking any questions.
Deepak, that was a wonderful presentation. Thank you very much. There are a few questions, and I'll put them to you from the audience. But before I ask their questions, I'll ask you a brief question, which is, in the patients where there was no biliary sphincterotomy, did you see what sort of impact that had on sludge formation within the stent?
Yeah, so I think when we came for stent removal, there was more sort of sludge accumulation. We performed balloon trawls with a sort of a 9 to 12 millimeter dredging balloon, which usually comes out. If there's any concern that the sort of contrast wasn't draining, then at the second ERCP, a sphincterotomy could be performed. But if it's not needed, then we don't always perform a biliary sphincterotomy.
Sure. Okay, I've got a series of quick questions for you. Quickly, dilate before you place it, or no dilate before you place the stent?
So I think it's down to the individual endoscopist how much you struggle to traverse the stricture, and we would dilate. Obviously it depends on the size of the duct. Between 6 and 8 millimeters dilatation, but it's down to the individual endoscopist's call at the time.
Yeah, may I add one comment? living donor liver transplantation, the anastomotic stricture is very sometimes tortuous and actually angulated. In those cases, before the stent deployment, dilation of the stricture may make it easy for the stent deployment. Therefore, in those cases, I always perform the balloon dilation before stent deployment. Yeah, go ahead.
Next question is, have you encountered a situation where you get the wire across the stricture, but nothing else will follow? And what's your sort of strategy to push through a very tight anastomotic stricture?
So I think, sometimes there are cases which can be quite frustrating. Normally a 4mm dilatation balloon will traverse the stricture, and then you feel confident you can dilate it serially 4, 6, 8, depending on the size of the duct. But those cases are quite rare. When they do occur, then you have to make a call of what you want to try and push through with. So again, it comes down to your sort of confidence with some of the accessories that are available.
Yeah, I do know that a 6 French cystotome has been used for very difficult, tight fibrotic strictures to punch through, and that's been done quite safely. Any potential bleeding, once you put the fully covered stent, should compress that. When do you give up and go to surgery? Is the answer always never?
If there, I need to know if there are any surgeons on this webinar. But I think our surgeons, are much more reassured with the use of the cafe stent. So they, some say, oh, I think they need a cafe stent, and they're not really pushing towards biliary reconstruction anymore. Our rule used to be 3 ERCPs and stent, and then they'd go for reconstruction. But since we've introduced it in 2016, there's been very, very few biliary reconstructions required.
And the last question, just quickly, is your colleagues in Leeds say that they occasionally place a plastic stent initially, and then when they come back, if the stricture doesn't look like it's resolving, they'll go to metal. But would you consider an option like that, or always go straight to metal up front?
I think we've had such good experience with the cafe stent, good sort of clinical outcomes. We go straight with the cafe stent. We certainly wouldn't do that, no.
Yeah. When we first started using it in Sydney, it was quite funny how the surgeons actually changed the playing field. Initially, they were horrified at the idea of putting in a metal stent. And by the end of the study, they were coming down and asking me, look, don't put the patient on the study, just put the stent in, will you? And I said, no, we're completing randomization. And that changes the way people practice quite, at least in our center, it was quite dramatic.
Yeah, I think we had similar experience. And also when you see the cafe stent with the string, it looks like it's almost fallen to bits for the first time. So they're like, oh my God, you've placed the stent and it's up the duct. And I said, no, it's all planned. Don't worry. So they've come on board as well.
So Dr. Lee, Professor Lee, any questions?
Yeah, another question or comment, because in Western countries, there are not so many cases of living donor liver transplantation like the Orient. But in Korea, we have if you look at the liver transplantation, the number of living donor is much higher than the total liver transplantation. Therefore, in those cases, the treatment of anastomotic stricture, the multiple plastic stent insertion is not successful in the many cases. Therefore, I believe in those of the patient after living donor liver transplantation, if they show the anastomotic stricture, the cafe stent is the best option, treatment option. And in case of after the total liver transplantation, the stricture level is a little bit lower comparing to the living donor. In those cases, we can think about 3 options. So first one is the multiple plastic, and the second one is the conventional long full covered metal stent, and the third one is the cafe. But I think the cafe may be the best one, because when we compare the cafe and the conventional long full covered metal stent, the cafe shows no serious adverse events such as the severe pancreatitis. In some cases, if you use the long full cover metal stent without string, the full cover metal stent can cause the severe pancreatitis in the small portion number of patients. Therefore, I think the GAFE stent is very good. Those patients suffer from the stricture proximal and the middle level of the anastomotic stricture.
Can I also make a final comment on this issue? And you raised a very good issue, Professor Lee, is that not all benign strictures are the same, just like not all anastomotic strictures are the same. And when you read the literature about benign biliary strictures, I think it's important for the reader to always think about what type of transplant stricture or biliary stricture are we talking about, because pancreatitis is very different to anastomotic stricture in living donor, as a deceased donor, so forth. I think a lot of the literature puts all these patients together in one group and studies a technique. And I think what should happen is we should isolate the indication, the specific stricture, and then talk about the different stents and the different techniques for each specific case. Always have this insight when people bunch benign biliary strictures together. But I think maybe we can move on to the final talk. If Professor Lee, you can introduce the speaker.
Okay, thank you. Yes, is there Dr. Moralevi? Are you ready? Maybe still sleeping? In Mexico.
Dr. Mora is experiencing technical difficulties. However, he sent us his presentations beforehand. So we'll cover, we'll play his presentations, and then we'll have an overall discussion session after the presentation.
Okay, until you are ready, we will enjoy some discussion more. So as the Dr. Cafe said, there are many kinds of benign stricture, including the benign stricture caused by chronic pancreatitis. But I think the main drawback of using full cover metal stent in treatment of benign biliary stricture is the previously high rate of migration. But the central waste can prevent the migration mostly. Therefore, the main, most important technical tip is to placing the central portion of GAFE stent at the anastomotic stricture. Then we experience very low rate of stent migration. But if we see the benign biliary stricture due to the chronic pancreatitis, sometimes they show very long segment of stricture. In those patients, I think the conventional long full cover metal stent is better than the GAFE stent. Yeah.
Yeah, and I think you're right, Professor Lee, because when you look at the original data using the traditional metal stent for the chronic pancreatitis stricture, most of the migrations were actually in the anastomotic stricture group of patients because the indications were all together. So the migration rate was very high for anastomotic strictures and was a lot less for your chronic pancreatitis. Sometimes selecting the type of stent for the type of stricture will give you a much better outcome in each specific indication. So that's where the literature needs to be dissected and clarified a little bit more.
And one more time, are you ready?
Yeah, we're ready.
Okay, then. Okay, let me introduce the last speaker, Dr. Jose G. Dilla Moralevi from National Cancer Institute, Mexico. He will be talking about less common and potential future use of the GAFE stent. Dr. Moralevi, please.
Good night, everyone. It is a pleasure and an honor for me to be part of this webinar in which I'll be talking about less common and potential future use of the CAFI stent. I have no conflict of interest, and I should point out that the possible uses of the stent described here are outside the current indications and should not be taken as guides to treatment of the conditions described. So what makes the CAFI stent so different? First, it has a short length. Second, it has the radial force concentrated at the center of the stent to prevent migration, and it has a long platinum loop for easy extraction. The current indications include post-liver transplant biliary stricture and hepaticojejunostomy anastomotic stricture, which you have heard from the previous professors. However, I don't see any reason why it couldn't be used in any other post-surgical stricture. By these, I mean the ones that are not associated with liver transplant. So we know that stent treatment of postoperative strictures is an accepted means of treatment. And there are numerous different protocols of which you are quite familiar with, I'm sure. The one from Amsterdam, Guido Costamagnus, and the one we perform at our institution. Now, the success rate goes from 70 to 97.5% with a recurrence rate over the years of approximately 11%. The predictive factors, for success are recent stricture, if the stricture is short, and preferably if it's straight or of the types 1 or 2. All the stents you can get in technique. So this has been tried before. This is a preliminary study by Michel Cahale, in which he used temporary placement of covered self-expandable stents, and he found an 87.5% success rate in 16 patients, which is quite good, and at least comparable to the protocols using plastic stents. Another indication is in between biliary radiofrequency applications in patients with cholangiocarcinoma. As you well know, the papers that have results on this have used mainly the Habib probe, and there's also some others coming that are probably easier to insert. But this is important because this is blunt. This is a blunt tip, and sometimes it's not so easy to advance through a stricture. So we know from literature that most studies suggest that RFA is beneficial if used with stenting and is better than just stenting, as this graph shows. So the patients treated with RFA have a longer survival than patients that are treated with just stenting. Another indication is probably in selected primary sclerosing cholangitis strictures. And so we know so far that balloon dilation is similar to stents, although if you go and dissect this paper, well, there are some details that would need to be clarified. But anyway, at least for short-term stenting, that is 1 week or at most 2 weeks, there's no difference apparently with balloon dilation, and actually there is a higher risk of complications, and that includes especially cholangitis. So according to the most recent guidelines by the European Society for Gastrointestinal Endoscopy and the European Association for the Study of the Liver, we have 17 suggestions, of which I have highlighted this one, which suggests that stents should be used for treating dominant strictures, but should be removed 1 to 2 weeks following insertion. And this is a weak recommendation with low quality evidence. And this is because mainly most patients have to undergo several procedures to check if they develop early cholangiocarcinoma, not just because of jaundice or cholangitis. So in these patients, it might be possible, if they do have a dominant stricture, to use a CAFI stent. Now, here we have many studies, mostly retrospective, that compare dilation to stenting or dilation plus stenting in PSC patients. And I have highlighted these results. I'm sorry if they're too small, but mainly what they show is that in patients that receive stenting, cholangitis is more frequent. Now, I wonder if that is because the stent is very small. So sometimes it is very difficult to pass a large stent, but probably if you could insert the CAFI stent and then it would open, it would probably help if it's not there for too long a time. So this is a very controversial indication, I know, but it could help, possibly. Now let's see. Here we have on the left side, the right intrahepatic ducts are extremely affected by PSC, and but there is one dominant stricture in this case where the left hepatic duct ends, and here there's a very slight decrease in caliber just distal to the confluence. So, well, maybe we could place a CAFI stent in this area or in this area uh, using these cases as examples. Another indication is as an aid or bridge for cholangioscopy. And so we've had the new spyglass for some years. And those of you that use this older model remember that it has the fiber, the optic fiber, separate from the actual endoscope. So when we found strictures like this one that is more proximal inside the branches of the left or right ducts, it was easy to pass the fiber through. With the new one, well, sometimes even we tried passing the optic fiber through a sphincterotome, and then we could have excellent images and then do blind biopsies. But with the new instrument, um, everything is included in this endoscope. So sometimes it is not possible to traverse some strictures. For example, here is an MRI of a patient in which you can see at least two strictures. And what if the first stricture is inflammation, but the second stricture is cholangiocarcinoma? So in order to get to that stricture, obviously you could argue that you can simply dilate this area and then pass the spyglass, but sometimes it's not that easy and it can bleed and it becomes a little more difficult. So in those cases, maybe if you place a shorter stent in the proximal stricture, you can reach the one that is more proximal. Now, this is one of the indications that I like the most. And now that we have EUS guided drainage of and everything that's around the digestive tract. There are some examples. Pelvic abscesses. These are very difficult to drain using regular interventional radiology techniques because of their location inside the pelvis. So instead of just placing a simple double pigtail plastic stent, you could easily place a CAFI stent and then remove it. Although there are some other stents used for this purposes, it is not always possible to have enough space to place, for example, a Spaxis or an Axios stent. And definitely the diameter of CAFI stent would be very beneficial and probably much better than a plastic stent. So that's one possible indication. Also, for abscesses that are located beneath the diaphragm on either side. And here is a cartoon showing the possible approach. And here's an actual patient that we did, where here is the abscess, and we placed a double pigtail stent. However, you can see how it disappeared with the stent, but I believe that a CAVI stent would have been pretty useful here. Remember that the center has more radial force, so that prevents its migration if you want to compare it to any other covered stent. And the other area in which EUS allows us to treat is the mediastinum. So this is a case of a mediastinal abscess. This is a report that's quite old. However, we've done a few recently as consultants for the National Respiratory Diseases Institute. That's beside our Cancer Institute. So here again, they use, actually, this is a straight plastic stent. So you could use a pigtail, definitely, but this could also be an indication for a CAFI stent. Now, this is very interesting. I've drained several biliomas and abscesses, always using a pigtail, double pigtail stent. But here, Dr. Tonosuka reports this 5 years ago, in which he drained using EUS and a covered metal stent, a bilioma, and also a liver abscess. So I believe this is a good indication also, and mainly because in this case of the hepatic abscess of the size, so you probably wouldn't be able to place a Spaxis or an Axia stent, a lumen-opposing metal stent. And in this case of a biloma, you could also it would also be very difficult to place a lumen-opposing metal stent just because of the distance. So a CAFI stent would be a good option. Now, we can also access the pancreatic duct using EOS. So since this has been possible, like in this example where we are performing a pancreatography using EOS from the stomach, it has also been possible to advance guide wires and place through the guide wire, over the guide wire, plastic stents in order to drain the pancreatic duct as you would in a surgical procedure like the Fry or the Pusto or other variants. However, the diameter which you can get with a plastic stent is much, much smaller than the one you could get with a metal stent. However, most metal stents are too long and have a large diameter, and also do tend to migrate, in this case, into the stomach. But the CAFI stent could possibly, because of its shortness and the radial force that impedes the migration, could very well be a good option to provide a larger communication and thus a better drainage. And to facilitate pancreatoscopy in a similar way as cholangioscopy, or in cases in which you will have to perform repeated entry into the pancreatic duct, and by this I mean repeated, not necessarily in weeks or months, but basically during the same procedure or in a short period of time, let's say some days, at most a week. For example, on the left, these are only examples. This is a stricture at the top, pancreas on the left, in red. So it's impossible to advance the pancreatoscope or the spyglass in this case. Here, you might be able to advance a little bit, but all the rest of the pancreas is not seen. However, in this case, there might be, for example, in the bottom pancreas on the left side, could be a tumor, and you would not be able to see it. So you could place, like in the right cartoons, you could see that precisely at the site of the stricture, which in this case is short, you could place a CAFI stent temporarily to help you advance the pancreatoscope to the end and see and be able to explore completely the duct, and then after that you can just pull out the stent. Now, repeated entry, the gold standard currently for pancreatic stones is extracorporeal shockwave lithotripsy and then extraction of the fragments. However, we know that this isn't always as easy as it sounds. And another possibility when this fails is before surgery, trying electrohydraulic lithotripsy or laser lithotripsy using also the spyglass instrument. So in these cases, you might be able to use extracorporeal shockwave lithotripsy and then place a stent. So you can go in and crush the remnants or do whatever you have to do and go in and out many times easily, and to facilitate maybe some fragments coming out. And it doesn't really matter if the branches are occluded because you're only leaving the stent there while you perform this extraction. And it also helps if you have to go in with the pancreatoscope or spyglass and perform direct EHL or laser. So that could be also an indication. Finally, the patients with disconnected pancreatic duct syndrome, which is quite frequent lately. I mean, it's always been there, but we weren't able to do much about it. The current treatment is obviously to connect the disconnected portion of the pancreas to the rest of the pancreas so it can drain into the duodenal lumen. So for that, what we usually use is a pancreatic stent, and that's usually plastic, and it can vary from 5 French to 7 or even 10 French, depending on the caliber. And very interestingly, the company that makes the CAFI stent also makes the bumpy biliary stent, which can also be used in the pancreas. However, if the portion that is broken from the duct is very short, there is really no point in trying to place a very long stent. So even though the new design metal stents for the pancreas don't produce so many post-treatment strictures and pancreatitis, I believe that if you can bridge only the part that's broken, it would be better. Now, let me just comment that the largest study using metal stents in the pancreas showed precisely that they should not be used because the ends of the stent can cause granulation tissue and strictures, and obviously the absence of holes can impede the drainage of the side branches and thus cause the pancreatitis. And that's another reason why I think maybe, just imagine this drawing, you could bridge the area of the disconnected duct with also a CAFI stent, and then leave it there as is usual 2 or 3 months, perform pancreatogram, and then remove it. So many of these indications might be controversial, and one time or another we've used them, and maybe this helps also the makers of the stent introduce some minor modifications, although their number of stents that they have is huge. And thank you very much for your attention.
Thank you very much, Dr. Murarebe. He introduced extended hopeful many indications of CAFI stents. Theo, is the Dr. Murarebe available now?
Unfortunately, Dr. Moore had technical difficulties, so we had to show the recorded version of his presentation. At this time, I would like to ask the moderators to lead us in discussion and have an overall Q&A session. Thank you.
Okay, then we will discuss about this issue without Dr. Murarebe. Dr. Cafe, do you think the CAFI stent can be applied as the lumen opposing metal stent?
Well, I think, Professor Lee, before we had the Axios, which is the preferred LAMS stent today, many people were using fully covered metal stents to drain various things from the gallbladder to pseudocysts to areas of necrosis or abscesses. So this is not new. Whether putting in specifically the CAFA stent in this situation to help prevent migration or to have the safety of the retrieval string so that if there's a migration into a cyst or into a cavity so you can pull it back. Look, it's not something I've done, to be perfectly honest, but it's something that could be considered if you thought, as the presentation by Dr. Moralevi showed, that there are some circumstances where an Axios would not be easy to place. It's not, you don't have the desired 3 or 4 centimeters to deploy that internal flange. So it could be of some use in these cases.
Okay. And the second question is do you think the insertion of CAFA stent into the pancreatic duct is feasible and safe?
I think anything in the pancreatic duct makes me nervous.
Yeah.
But we are increasingly using stents like the bumpy stent for EUS-guided pancreatic drainages. I think the presentation by Dr. Moralevi essentially is telling us a lot of very specialized single patient indications, which I think is something that we all often do. We'll find a device or a stent or something to rescue a situation. But specifically using metal stents in the pancreas is something that's fairly new. There is an emerging literature. I know that Jacques Devier has been a real leader in this area, using fully covered metal stents for indications such as benign pancreatic strictures. And there has been some increased use, as I said, of the stents using EUS-guided drainage. But I think this is an area that if you are going to do this work, it should be an opportunity to do it as a research protocol, as published data, because we need, just like with the initial metal stents in benign biliary strictures, we needed people to emerge the literature and show the safety and then the efficacy and so forth.
Yeah.
So what we can do with it, well, I think that's yet to be determined.
Yeah, I agree with you. Previously, I experienced a few cases of full-core metal stent insertion into the very advanced chronic pancreatitis. They have the very atrophied parenchyma and the tight stricture. But in terms of the stricture resolution, it may work. But in many patients, after deployment of the stent, many patients complain about very severe pain. Therefore, we have to remove the metal stent in the many patients. Therefore, I think it is not easy to insert the full metal stent into the pancreatic duct. And even the Dr. Moralevi did not mention, I published the article for another indication of CAFA stent. In patients after the magnet compression anastomosis, we can have the newly formed fistula tract. I insert the full metal stent for 3 months to reinforce the new fistula tract. Then it is very good to maintain the new fistula tract for a long time. Yeah. Do you think any other indication for the use of the CAFA stent?
Yeah, look, I think Dr. Moralevi covered a lot of interesting possibilities. I think the next step in the development of stents and the biliary tree or even the pancreas is to better understand, as I said before, the specific indications. I think people are still very quick to put all benign biliary strictures together, but they're so different. And maybe developing modifications to the stent to suit the hepatico-jejunostomy strictures, and so forth. I think this is where the next phase of research should be. It should be in the areas where we can focus on understanding the absolute optimal treatment. Biliary leaks, you know, as Dr. Joshi showed, some Maritzi syndrome. All of these things are possible, but they're usually unusual cases, and you pick a device to use it. Do you see an emerging area for this particular stent?
No. How about Joshi?
So I think what the last talk showed us is that as we get, you know, to understand the stent, we are using it for different indications, and it does come down to the individual endoscopist's experience of the stent. So I think the comment about PSC, common hepatic duct strictures or hilar strictures, the smaller diameter stents, you know, we can use these. There's no reason why we can't, and you get the absolute sort of you know, radial force where you need it, as opposed to further down the duct as well. And I've not used the sort of the smaller diameter stents, so I don't know if anybody else has, but certainly I think, you know, as we sort of get more confident, we can use these. But my comment in the pancreas is, you know, I get sort of anxious in the pancreas. Things can go ping, and then you can struggle to get it out. I think the biliary tree is more forgiving than the pancreas, and certainly if you're going transpapillary. And then the last comment of, you know, if there's sort of transection of the pancreas, usually those cases are in pediatrics, and the duct will not take a fully covered stent. And, you know, sometimes you're just lucky to get anything across the transection as opposed to a metal stent.
Yeah, and before we finishing this session, I would like to ask to Taewoong. I would like to ask some modification of cafe stent for the better treatment. For example, we talk about detachment of the silk thread, and we talk about the stent blockage by the sludgy. Now, I wanted to hear from the Taewoong Medical Company. Can you give us the explanation about the stent modification in the near future?
Professor Lee, thank you for the question. Yes, we'll be working on it, and we'll be talking with our development team in making such changes in the near future. Okay,
I will believe you. Okay. Is there any comment or questions? Okay, Taewoong, can we close this session? Okay, before
yes,
closing the Dr. Cafe, please give us the small talk before close this whole session. Yeah.
Look, I want to thank all the speakers for their great presentations. I think all the areas are of great interest, particularly to the transplant units around the world. And I thought the presentations were excellent. Looking at indications, looking at pathologies, and looking at future possibilities. I want to thank the Taewoong Company for supporting this meeting and supporting, at least, if I can go back 10 years to the development of the stent. They were very good, and I urge any participant, anyone listening in that has any good ideas to talk to Taewoong. It certainly worked very well when I worked with them. I also especially want to share my thanks to my co-chair and good friend, Dr. Dong-Ki Lee, who has also been a very strong specialist in the area of biliary endoscopy and also stenting, and published some wonderful data, not just with the CAFA stent, but in many areas. And I urge all the participants to follow suit, follow the direction of such a great leader, do good work, publish the work, and change the way things are done. So thank you very much to all the participants, Taewoong speakers, and my co-chair. Thank you very much.
Okay, thank you very much for all the speakers and joining this meeting. And I would like to also thanks to the Taeyong for the supporting us. And the last but not the least, I would like to also thanks to the Dr. Cafe who introduced this beautiful stent. Despite of this pandemic, I hope all of you stay well and stay healthy. Thank you very much. I will close this session.
Thank you so much.
Thank you, Professor Kafis and Professor Lee, for your amazing moderating of the webinar. We would like to express our gratitude to all the speakers for their presentation today, as it was very informative for us all. As we end the webinar, I would like to wish that everyone stays safe from COVID-19, and we will come back to you with more webinars in the coming months. Thank you.